Good afternoon, everyone. I'm Dr.
Very good
Niharika.
afternoon.
Hi, Dr. Shipali. Can you please mute your mic?
Yeah,
Yes. So, hi, everyone. I'm Dr. Niharika Jain Gupta. Welcome to another fabulous session of One Among You. This is third in line, third episode of first part of One Among You series. And today we have a very passionate, remarkable, outstanding dentist with us, Dr. Sagar Shah. Dr. Sagar Shah has eventually won second prize in the beginners category of endodontic case contest that was recently organized by Epistate Health Singapore. And he shared his remarkable case with us. And today he is going to talk about the case, his prize winning case with us. Just a minute. I think some people are joining. Yes. Yeah. So let me introduce Dr. Shah. Dr. Sagar J. Shah is an endodontist. He is a founder of Endo Essentials, an educational wing which is aimed at continuing dental education through through his series of lectures and continuous hands-on workshops. Dr. Sagar Shah has been recently awarded as fellow in by Style Italiano Endodontics. Congratulations, Dr. Sagar Shah.
Thank you.
Then he is an overseas educational consultant for Dental Window Private Limited. He has been also awarded with Budding Dentist of the Year by FAMDent Excellence in Dentistry Award 2025. And he has been awarded with Endodontist of the Year, highly recommended by FAMDent Excellence last year also in 2024. Dr. Sagar Shah is recipient of Student of Merit by Perry Foucault Academy, USA in the year 2018. He has also been awarded with Student of the Year in 2017 and Dental Researcher of the Year in 2021 and IHPA awards. Dr. Sagar Shah has published 8 international and national papers. So let's welcome Dr. Sagar Shah. Dr. Sagar Shah, we welcome you to this show. Over
Yes.
to you, Doctor.
Yeah. Thank you, ma'am. Thank you for the wonderful introduction. So, today we are here to have the clinical skill enhancement series. So, I will be discussing my winning case over here. So, whenever you are ready, ma'am, I'll start my presentation.
Please, let. I request all of you to mute themselves.
The screen is visible with everyone. Ma'am, can you see the screen, right?
Yes, it's visible. And one more thing, if anybody has any doubt, they can please post in the chat box. So Dr. Sagar Shah can reply in the last. Thank you so much.
Okay. So today we are going to discuss the case which won the second prize in the beginners category in the EP state uh, competition. Okay, so the case was titled as "Catch Me If You Can: Dancing Mirror on Top of the Mandibular Canal." Before we start, all these things started with when I started this Endo Essentials, a brainchild of mine, which is dealing with conducting continuing education programs and making sure that endodontics and dentistry is feasible, doable, and repeatable for all of us. Okay, and this all started back in 2017 when I had an opportunity to conduct a workshop and lecture at a conference in Goa. And since then, I believe that in learning, you will teach. and in teaching you will learn. The most recent conference that happened in Feb this month, this year, okay, I was awarded with the Fellow of Style Italiano Endodontics, and this is something that I keep on doing every now and then in my clinical practice. Okay, these are the cases which we get on and off, and this is how they are done. But this is something happens when you're looking for it. I believe that opportunity knocks when you're looking for it. And during my FAMDENT Awards this year, I was introduced to Epistate Health. Okay, so I received a complimentary pack of Epistate Health Rotary files, okay, Epident files, and I used it for a couple of cases. I liked those files, and then one day I came across this competition, and the second day I landed up with this. Okay, so a key takeaway for all of you is whenever you have a case which is difficult, different, you are not going to attempt the case on the same day. You are going to take a break, you are going to take a day or two off, and then you are going to go ahead with the case. That is what I call as visualizing is daydreaming with a purpose. You wait, you pause, you take your time, you formulate a strategy, and then you come up with the results which may or may not look something like this, but this is what you want your end product to be. So, with all this being said, I want you all to brace yourself for this adventure in understanding the science behind management of dancing molar on the mandibular canal. Okay, with this, we start with the technical part of the presentation, wherein we divide the presentation in 4 different parts. How difficult is difficult, selecting the right tools, executing the flawless plan, and then we end the presentation with present status and future directions. Okay, now the first and most important is how difficult is difficult. Okay, so for me, something might be easy which might look difficult to you. Okay, so we need to have a standardized pro forma, or we need to have a standardized plan wherein we can categorize the cases. Okay, so we understand what to attempt and what to refer. With that, this is the pro forma that is going to be present with you always. Okay, I want you guys to imbibe this pro forma. Your any case that comes to your clinic, you are going to divide it into 3 parts. Okay, the anatomical difficulty, pathological difficulty, and practicality. Okay, with this you are going to categorize the case as easy, moderate, and difficult. And why I'm discussing this right now instead of discussing my case, because I want you guys to have a blueprint of when to attempt or when to refer. Okay, so easy case, as you can see, is simple straightforward case which is doable for around 80-90% of dentists. Moderate is something which is going to require a little bit of more proficiency and you can attempt it. But difficult is something that you need to be referring out, or you need to be highly trained with it. And what do I mean by difficult? Second or third molars, crown morphology is inclined, there is root curvature which is more than 30 degrees, most important, proximity to vital structures. Lower sevens are difficult due to their proximity to the vital structures, that is the mandibular canal. There is periapical disease, there is resorption, there is trauma, and there is systemic disease. If you have all of these things, make sure that you are following a very stringent plan of action. Okay. Now, today, as we are discussing only dilacerations, or we are discussing my case, I am going to discuss with you about how do we go about a case which comes to your practice. Okay, any damn case that comes into your clinic is going to go through these 2 things: measurement of radius of curvature and measurement of curvature, angle of curvature. And why you are going to do this? Because if you do this, you are going to understand whether it's easy or difficult one. Okay, so now first let's start with measuring the curvature. How do you measure a curvature? You draw a line perpendicular to the orifice, okay, the long axis of the tooth, and at the point of angle or at the point of curvature, you draw a line parallel to it. Okay, and the angle between the long axis of the tooth and the angle becomes your angle of curvature. Okay, so if this angle is anywhere between 0 to 10, it's an easy case. 10 to 30 is a moderate case, and above 30 I will recommend everyone to start praying. Okay, because that is the kind of case which is going to require maximum efforts. Now with this, you are going to do one more thing. You are going to measure the radius. Radius about what? Radius of this thing over here. Okay, so basically this here, the line parallel to the long axis of the tooth, along with it there is going to be a circle which is drawn, and that is the radius. More the radius, easy to manage, that means gradual the curve. Less the radius, that means more difficult the case. Okay, so this here case is and probably a difficult case, okay, which has a radius angle around 30 degrees, another around 46 degree, and this is the kind of case which has a 90-degree curvature. So this is going to be the most difficult one. Okay, I'm not going to go individually with these cases. We are going to stick to our case for the day. Okay, now coming to our case. Okay, this patient had reported with pain with lower right mandibular posteriors. Okay, and this was a referred case. This case was referred to be my colleague because one, there was lower 8, second, it was just overlapping the mandibular canal, and third, highly lacerated. So extraction, if you would have done, it would have been a problematic extraction. So conservatively, the patient had an upper molar present, so we decided to go ahead with the root canal treatment. Radiographic analysis, there is occlusal radiolucency involving enamel dent in pulp. I want you to appreciate the pulp chamber over here. It is calcified, there is dilaceration, there is pedial widening, and it is superimposed over mandibular canal. Okay. After that, we did the same thing that I just taught you. Okay. We measured the curvature and the radius. So in the mesial root, the curvature was around 63 degree. That is around almost nearing down to 60 to 70, which is highly difficult according to A terminology. And in the distal part, it was around 37. Okay, and this is the difference that I was speaking about radius of curvature. Less, smaller the circle, sharp the curvature. Okay, larger the circle, more gradual the curvature, easier to manage. Okay, so this was the case analysis which I did before I attempted the case, and even this is a practice which I do in my day-to-day cases, that I anticipate complications. Okay, mesial case has 60 degree, distal has 30. There is radius of curvature, close proximity, and pulp calcification. So I have to take care of all these things before I proceed to this case. Okay, this is what God has sent me, a case. Now the second part which I have to do is select the right tools. Okay, so you have to be sure about the tools you are using. You have to make sure that you are using the right tools for the right purpose. Okay, so first and the most undervalued thing in dentistry is a mouth mirror. Whenever I am going to work on a lower third molar, second molar, I want visibility and I want space when I put my rubber dam around it. So I am going to prefer a number 3 or number 2 mirror, which gives me more room to work with my endomotor when I am doing a rubber dam. Okay, now another important part is your hand files. Okay, in dilacerated cases specifically, you are going to use 21 files. Okay, because you want to have a better tactile sensation. Second thing is, you are never ever going to use straight files. Straight files are never supposed to be used in endodontics. You are going to make sure that you are giving a gradual curve, and in some cases I will be discussing later, you are going to give sharp apical curves. Okay, this was all about your hand files. Now coming to the important task of what rotary to be using. Okay, so in market today you have more than around 250 to 300 brands of rotaries available. You have rotaries available with all the cross sections, all the heat treatments, all the different brands, and everyone claims that their brand is the best. Okay, you should be not falling to this marketing gimmicks, and you should be understanding what has to be used where. Okay, so a general schematic of rotary files looks something like this. It has a cutting edge, it has a helix angle, it has flutes, and it has a tip. Whenever you are selecting a rotary file, specifically for such curved canals, you are going to select a non-cutting tip. Okay, you want actively cutting flutes, and you want the cutting edge to be on a negative side, so you have active cutting. Okay, another part is you have nowadays every file comes with a different color. Okay, it's just not color, but it's the material property along with it. So you have blue wire, you have austenite, you have gold, you have CM. Austenite is not supposed to be used in such cases because they are rigid files. You are going to go with either gold wire, blue wire, or CM wire. Okay, gold wire is more what you say, flexible, not more flexible, it is more, it has more cyclic fatigue when compared to blue wire. Okay, so good cutting and good flexibility. Blue wire is more flexible than gold wire, but it is little bit less cutting when you compare with a gold wire. And CM wire is has control memory feature. It is very good with flexibility but less cutting. Okay, so preferably you are going to go with either gold, blue or CM with whatever works best in your hand. Okay, I am a big fan of gold wire, so in all my cases I prefer gold wire unless I require blue for certain cases. Okay, with that being said, then comes cross section. Everyone or all the medical representatives will be coming to you and telling mine is triangle, mine is S shape, mine is a circle. What difference does it make? It makes a difference because the cross section determines how the file is going to behave. Okay, a triangular or a convex triangle cross section is the safest cross section because it has a good core diameter, so your file is not going to separate even when subjected to stress. Okay, so in such cases you are going to go for a convex triangular cross section. Another choice can be S shape, but remember a word of caution that S shape cross sections are prone to separations, okay, if not used properly, because the core diameter is less. They're excellent files, but you have to use them with caution. Triangle offers a balance between cutting and safety. Okay, so this is what all I did for a couple of days before starting the case, and with that being said, I came up and narrowed down to V plus gold files from Epident. Okay, now if I tell you that I am using these files for the first time while doing this case, I'm lying. Okay, as I mentioned, during my Famdent Awards, I received a pack and I was highly impressed with it. And then when I came across this case, I thought that it's worth giving a try. And why I selected these files, because they're progressive taper files, so the question of taper lock is eliminated. They are triangular cross section, so it's going to give me a good cutting with a good safety feature. Heat treated, so cyclic fatigue is increased, and it has non-cutting tip. That means it's not going to cause any strip perforations while I prepare it. Okay, with all this in my mind, this was all the selecting the right tools. Then we come to executing the flawless plan. Okay, on the day of uh, treatment, the first thing that you do is give a good local anesthesia, isolate, and the first thing is access opening. A well done access opening is around 50 to 60% of the procedure. We started with SF12 followed by safe and burr to achieve complete de-roofing. Okay, ultrasonics was used to define the axis, and this part what you can see on the screen here is nothing but a flowable composite. This is your flowable composite used as a pre-endo buildup because it's a lower third molar. I don't want my hypo to be collapsing in the pharynx. Okay, so isolated, pre-endo buildup done, and this is how an access opening looks like. Okay, then comes an important part is how do I prepare it. Okay, now whenever you have such a case, you have to be very methodical with your way of preparation. Okay, for this specific case I use zone technique. Now what is zone technique? Zone technique is nothing but crown down technique by dividing the tooth in above the curvature and below the curvature. Okay, I am repeating again, zone technique is nothing but crown down technique by dividing the tooth into above the curvature and below the curvature area. Okay, so what we did is we first started with pre-flaring. Okay, why pre-flaring is done? You want to eliminate all the coronal interference. Okay, make sure you are just doing pre-flaring 1 to 2 mm in the orifice, as you have the, you can see this dotted line over here. Okay, so that is the amount of pre-flaring that you are going to do. Second thing is you are going to start with coronal enlargement. Okay, so the first file, that is v plus 1, was used till resistance in brushing motion. Okay, you are not going to force any files. The moment you have resistance, you are going to pull the file out. Okay, preferably this is not going to go more than 5 to 6 mm in the orifice. Okay, then what you do, you take a v2, that is the second sequence, third sequence in the epident files. Okay, you select the v2, you place it by hand, okay, till it is passive, and then you attach your endomotor on top of it. Okay, then you activate the files with 1 mm in pecking motion. Now what this does is, this is called as controlled activation technique. Okay, by doing this you are only activating 1 mm of file at one time without stressing the file beyond its limit. Okay, and please make sure that you are not going below the curvature. Right now, our aim is to limit our preparation till the curvature or above the curvature. Okay, so what happens is you have a good amount of area for your irrigant to be over in this part, while your smaller files are going to go down and shape the apical part. Okay, v1 v2 are nothing but shapers, so they have a good coronal taper. They are going to take care of the coronal enlargement, and then you are going to use the finisher files to shape the apical third. Okay, now you must be wondering, what about working length? Okay, the most common mistake that everyone does is immediately when you see the case, you have done the axis opening, you take a hand file and try to reach the apex. You absolutely don't do that. Okay, there is no point in reaching the apex without pre-kernel enlargement. Okay, so you first enlarge the orifices, do some enlargement above the curvature, and then with an 8K file you are going to take a working length. Now, what are the advantages of doing this thing? You have eliminated the coronal interference, so your file is going to glide through. Okay, it's not going to have any false readings, and it is going to be more easy to manage this thing. Okay, once you have working length with 8K file with watch winding motion, either by hand or either by using mechanical tools like K400, you are going to create a glide path up till 10 or maximum 15. Okay, do not go above 15. In this case I have only prepared till 10, and after that what I did is I cut around 1 to 2 mm from my 10K file, and I created a golden medium file, that is a number 12 file. Okay, so I created a 12 number file and completed my glide path, and after that I started with VF1 using brushing motion below the curvature in 1 mm increment. Okay, this is very very important. At no point in time the length of the file is engaged. Always only when 1 mm of file is engaged, and then you deactivate it, that is you pull it out. Okay, 1 mm and out, 1 mm and out, that is how we are going to do it. In the mesials I was able to shape till VF1, in distal VF2, because it was a huge canal. On this master cone radiograph I have confirmed my preparation, and as you can see that I can see some dead space even after putting my master cone in the distal one. Okay, now after my BMP is complete, I start with irrigation and activation. Okay, so hypo was there throughout my BMP, flooded in the chamber. After I have done my BMP, I have flushed all the debris with hypo and saline. After that, meticulous attention has to be given to removal of smear layer, and that is only done by EDTA. So what I have done is I have taken around 2 to 3 ml of EDTA. I have flooded the EDTA and I have kept it for 1 minute. You let EDTA rest for 1 minute, and then you start the sonic activation. So all the smear layer is taken care of, and then again one cycle of hypo and saline. That was all about irrigation and activation. Now in such cases you can't be using metal tips. That is why sonic activation with polymer tips are extremely helpful in curved cases. After I am done with all of these things, I start with obturation. My choice of obturation in such cases are going to be bioceramic sealers with GP using a down pack. Okay, I don't have to worry about uh, the what you say. I don't have to worry about my sealer getting extruded and causing any problems because it is in close proximity of mandibular canal. But while selecting a bioceramic sealer, you have to make sure it's biocompatible and it's of a good brand. And second most important thing is you are not going to inject it with force. Okay, you are just going to flow the sealer in the chamber. Please understand this thing. Whenever you are in close proximity to the vital tooth structures, you are not going to inject the sealer in the canals. You are just going to flood the chamber with the sealer. Okay, and as you put your cone into it, the action of putting the cone into the canal is going to draw the sealer inside the canal. Okay, that is how you are not going to end up with any potential mishaps. Okay, then you use down pack to shear it off. In this case I have done some cold lateral compaction with a distal canal. Okay, because it was a huge canal, I just did not want to flood it with sealer. So a little bit of cold lateral compaction with the distal canal and single cone hydraulic compaction with the mesial canals. And after doing that, this is the kind of post op that I could obtain. Okay, now if you can see here you can see something which is looking a little bit odd. Okay, this is exactly the point till where I was able to put my spreader inside the canal. Okay, that is why you can see there is this bulge over here. Okay, so this is what exactly it looks like. There is optimum seal, and I have topped it up with a core composite built up. Okay, so this is the kind of post op it looks. What I want no transportations, no perforations. I don't want any of my contents to go beyond the canals, because as you can see this is right on top of mandibular canals. Okay, I don't want any preparational errors. I want no zipping, no perforation, no separations. Okay, and if you have followed me carefully, you will understand the hand files were used in bare minimum numbers. I have allowed the normal anatomy to guide me throughout the preparation using heat treated files. Okay, flare the coronal part, use hand files to just gain working length, shape it a little, prepare a glide path, and then with 1 mm strokes you are going to reach till the apex. Okay, this is how it looks like: the pre-op, the master cone, and the post-obturation radiograph. Okay, this case was done in a single visit because I was pretty damn sure if I lose my orientation, I'm not going to get oriented after a week when I call the patient. Okay, so this case was completed in single visit using uh, cold obturation using bioceramic sealer and resin core, and finished it off. Okay, with this we come to the end of my technical presentation about how I manage this case, but this is not where it ends. I want you all to leave with present status and future directions, because sooner or later you are going to end up with cases which may or may not look like this. Okay, they may be like this or maybe even difficult than this. Okay, so whenever you are going to consider any pointers for drafting the plan and performing such cases, these are the takeaways I want you all to have. I want you to use a crown down technique for error free preparation. Okay, you are least bothered about reaching the apex at the beginning. You want to open up the coronal part, then you are going to go to the apex. You do not rush to the apex using hand files. Okay, heat treated files, you can use gold files, you can use blue files, that is your personal preference, but heat treated files show better performance in curved canals. Okay, austenite files cannot be shaping so curved canals because they are prone to separations, they are rigid files. Okay, in my day-to-day practice for majority of cases, triangular cross section works well. Okay, S-shaped cross section is excellent, but triangular in such cases will going to offer you better safety, and in such cases you are going to opt for a bioceramic sealer for optimum seal. Okay, because as you saw the distal root was still accommodating, having dead space even after master cone x-ray. Okay, so even with cold lateral compaction, I want to make sure that everything is sealed in a 3D manner for long lasting results. Okay, with this I come to the end of my presentation. These are my details. You can contact me on Facebook, Insta, email, and on WhatsApp, and I'm more than happy to assist you with any queries if you have.
Thank you. Thank you, Dr. Sagar. It was a wonderful presentation, especially the manner in which you highlighted each and every point, talking about case selection, the choice of instrumentation, especially talking about the characteristics of the file. That was really impressive. I hope this presentation will help each and everybody of us in understanding the morphology of the canal, selection of the instruments as per the morphology of the canal, and the techniques which you mentioned to counter these challenging cases. There is one question by Dr. Soni. So she
Yeah.
is requesting if you can please explain the radius case selection
Okay. So
again.
basically, she wants to understand about the radius of curvature and angle of curvature. Am I right, Dr. Soni?
Yes.
Okay. So,
Yeah.
radius of, let me just go back to the slides. Okay. So now let's look at the case that we have on the screen. Okay. You draw a line parallel to the long axis of the tooth, and you draw a line from where the curvature starts. Okay. The angle between these two becomes the angle of curvature. And what you do is you draw a circle which has which starts from the long axis of the tooth, okay, which is resting at the long axis of the tooth. So this diameter is nothing but your radius of curvature. Okay, this is
Okay.
nothing but the radius of curvature. The point should be at the intersection of the angle of curvature. Okay, so larger the radius means gradual the curvature. Okay, smaller the curvature means more acute the curvature. More acute curvatures are difficult to manage. As you can see, the mesial has a smaller diameter. This is a small circle, okay, and the distal one is a larger circle. So the distal one is a more gradual curve which we can manage when you compare it to a mesial curvature. I hope that is clear with you.
Yeah. Yes, sir. Am I audible?
Yes, yes, Dr. Soni.
Sir, I had one more question. In the end, you said you completed the case with cold compression, bioceramic sealer, and third thing, what did you mention?
Cold hydraulic compaction. So
Hmm.
basically you are going to use down pack which is at a lower heat setting for the mesial canals. Bioceramics, you can't heat it as routine other sealers because they are prone to losing their moisture. That is why you use a down pack at a lower setting around 150 to 180 degrees Celsius. That is nothing but cold hydraulic compaction.
Hmm.
Okay. Thank you so much.
Yeah.
Thank you so much. Is there any other question? Dr. Sagar, I just want to know, understand one thing. Normally, we say third molars are meant for extraction. So,
Yeah.
how do you decide? What is your selection criteria?
So first things, young patient has an
Hmm.
opposing tooth, we will go ahead
Hmm.
for root canal. Okay. Second thing, there should be no underlying what you say medical complications. Let's say
Hmm.
if this patient
Hmm.
had a type 2 diabetes or uncontrolled diabetes or
Hmm.
hypertension,
Hmm.
extraction would
Hmm.
have been traumatic. Okay. In
Hmm.
such
Hmm.
cases, an endodontic treatment would have been more conservative. Third thing, if the patient has the ability to utilize it, as in the patient does not have any signs of cheek biting, no trauma, and it is well aligned in arch, you will go ahead with root canal treatment. So whenever possible, as in if the patient can accommodate third molars, if they are fully in occlusal plane and if they are functioning, we should go ahead with root canal. And in another case wherein the patient is compromised for extractions, okay, root canal
Hmm.
treatments offer an suitable alternative for third molars.
Thank you. Thank you so much. I hope it's clear now with everybody. If you have any questions, please feel free to contact either of us. Thank you, Dr. Sagar. It was a wonderful presentation. Each
Thank you,
and
ma'am.
every point was highlighted in a very impressive manner. Thank you so much. And this is a small token of appreciation from our side. Just a minute. Hmm. Thank you, Dr. Sagar Shah. Thank you so much.
Yeah, thank you, ma'am. And I would like to thank Epistate Health for organizing such a competition and providing us a platform to showcase our work.
Yeah, as you know, the name of the event is the program is One Among You. So idea is to invite passionate dentists
Right.
amongst all of us to come and share their expertise, clinical expertise with us. It's actually boost confidence also,
Yeah.
and yeah. So I request each and everybody to please share cases with us, keep tagging us on social media, and stay tuned. We will invite you all someday. And definitely, our next speaker is Dr. Justin. He's going to speak about his award winning case in the next session. Also, the recording of this session will be available on YouTube and Instagram. So take care. Thank you, Dr. Sagar. Keep
Yeah.
sharing
Thank
your
you.
cases, wonderful cases with us.
Thank you.
Thank you so much. Take care. Have a happy Sunday. Bye bye.